We're going to talk today about PGT onset. The aim of IVF is to get a healthy full-term fetus. Use morphology means whatever the early human embryos are aneuploid, which is an aneuploidy is the main cause of implantation failure and miscarriage. We know that aneuploidy dramatically increase with age, and this explains the marked reduction in implantation potential in the older patients. Abnormal embryos can be aneuploid or mosaic. Aneuploid embryos have all the cells abnormal in the blastocyst, while in mosaic embryos, some blastomeres are abnormal and the others are normal. The aim of PGT-A is to deselect embryos with abnormal chromosomal number because they cannot self-correct. With PGT-A, with or without PGT-A, we'll have the same live birth. But with PGT-A, we aim at a better efficiency, lowering the abortion, lowering abnormal pregnancy, time to pregnancy, more single embryo transfer, and probably more cost-effective. Theoretically speaking, PGT-A should have the same cumulative live birth rate as transferring all the available blastocysts, one after the other. Still, the usefulness of PGT-A has been doubted since the early 2000s, especially in younger females. And conflicts still exist till now, despite the transition from day 3 to day 5 biopsy and the use of newer platforms like NGS. Actually, some RCTs fail to prove any benefit of PGT-A on live birth rates. And when results of multiple fertility centers are put in an RCT, PGT-A was unable to find any benefit except for patients above 35. However, including many centers with different experiences may result in losing embryos in the less experienced centers. And this is the condition probably with the STAR trial. And another problem is that they did not use mosaic embryos for transfer. The same conclusion was obtained in this, in which 13 centers were included. Actually, it was found that individual clinics have significantly different performances in routine outcome of PGT-A, and these are best PGT-A. In highly experienced centers, actually, the outcome of PGT-A is significantly improved. Many are benefit with PGT-A. Revising the live births from the HIFIA records using propensity score actually found that live birth rates are significantly better with PGT-A in all ages. Another controversial point, does PGT-A have a high rate of false positive diagnosis? Until recently, mosaic embryos were considered abnormal and were treated as aneuploid. And this is a false positive diagnosis because they were left unused in the past, and mosaic embryos actually may result in live births, and discarding them may reduce the pregnancy rate and the live birth rates. One question, does PGT-A have a high rate of false positive diagnosis? Until recently, mosaic embryos were considered abnormal and were treated as aneuploid, which is a false positive diagnosis, and they were not used for transfer. Actually, mosaic embryos may end in live birth, and discarding them will result in reduction in the pregnancy rate and live birth rate. The higher the technical error, the more likely that euploid embryos are incorrectly diagnosed as mosaic, and this is a false positive diagnosis, which will end in preventing a potential pregnancy. However, the error rate nowadays is very low, 0 to 2%, and it was the first time by Krigo who published that healthy babies can result from mosaic embryos. And until recently, mosaic embryos were described as abnormal, while they were actually mosaic and they can end in live birth. Further publications have shown that mosaic embryos can still end in live births and healthy babies. We have to differentiate between the true and the technical mosaicism. Actually, the instance of mosaicism is extremely low, and if it exceeds 5% in any particular lab, they should revise themselves. There are many explanations for the technical mosaicism, and mosaicism can be low or high. And concordance study actually confirmed that if the trophectoderm biopsy is euploid or low mosaic or aneuploid, the ICM will most probably be the same. The only problem is with high mosaicism diagnosis. 65% of them are aneuploid and only few are normal ICM. Mosaicism may end in healthy live babies, and the publication of 1,000 mosaic transfers can make a ranking system for how to select mosaic embryos and how to rank them. So mosaic embryos should be deprioritized and should not be discarded. Actually, clinicians became very worried when mosaic embryos ended in live births, and they started transferring totally aneuploid embryos. Unfortunately, this ended in failure of implantation or miscarriage. And it was not until a very well done non-selection study that has shown undoubtedly that aneuploid embryo transfer will eventually end in miscarriage or failure of implantation. And all the publications reporting transfer of full aneuploid embryos has shown that this ends in failure of implantation with only 2% false positive rate. Another question, does PGT-A have a high false negative rate? Older platforms like RACGH has a high false negative rate, and it may wrongly diagnose some aneuploid embryos as euploid. And if they are transferred, they will end in miscarriage. And this has been confirmed when the products of conception were analyzed. Another very important problem is the effect of the biopsy. Of course, the biopsy in day 5 is much better than day 3, and day 3 biopsy should be abundant because it compromises the implantation rate. And in experienced hands, the biopsy in day 5 will not affect the embryo, but only in experienced hands. Because if clinics with low experience have some losses, 30% loss and damage to the embryo, they will not be able to demonstrate any benefit if PGT-A is done in younger patients. So our recommendations is that patients should be counseled that PGT-A is not 100% accurate. We should prioritize euploid embryos and low-grade mosaic embryos together with morphology. A new stimulation cycle is not recommended when you have only low-range mosaic embryos. Low-range mosaic embryos should never be discarded. Rebiopsy is not recommended for mosaic embryos, and there is no specific recommendation for high-range mosaic embryos. Prenatal diagnosis is required. However, invasive prenatal testing is not needed when you have low mosaic embryo transfers. So PGT-A is undergoing steady global expansion. The methodology is constantly evolving. PGT-A is never 100% accurate. It has a high specificity and sensitivity. It's particularly useful for advanced maternal age. PGT-A should be individualized in advanced maternal age according to the center's experience, female age, ovarian reserve, fertility preservation needs of the couple, and their financial resources. Thank you very much.